morning, everybody. I think I'm talking to you after a very long time. It is very tragic, actually. We don't see the reactions of the people when we talk to an audience because of this COVID times. On one side, actually, the NCI says actually the online classes, they are not valid, and online examinations, they are not valid. We are completely in a state of confusion and dilemma. Anyway, we were asked to do it initially, and we continue to do it. Okay. So the next topic, actually, I'm going to talk about is community ophthalmology. So community ophthalmology, actually, it's a there's nothing to explain in it. There's mostly the statements which you will have to rather get it by heart and rather produce it in your theory paper whenever it's asked as a short note question. And in order, suppose if we ask you, we will have to answer them. Okay. So the most commonly what we ask you is in the examination, NPCB is one short notes question, DBCS is another, right to sights is another, and Vision 2020. And there are certain definitions you will have to answer when you are asked in the examination, which we'll come to in a short while. So community ophthalmology actually deals with appropriate strategies and methods to reduce the burden of eye diseases in a community, in a given community, be it here or somewhere else in the United States. So the practice of community ophthalmology, normally it involves an assessment of the extent of the problem of the particular eye disease and the socio-economic impact of blindness in the particular community. Okay, different countries actually, they will have different eye diseases, rather prevalence of eye diseases. If you take actually India, so the infections and also the cataract actually takes a larger role. And in case of United States, it's age-related macular degeneration and glaucoma actually, which contributes more to actually the glaucoma, the blindness, okay? So an assessment and extent of the problem of eye diseases and socioeconomic impact of blindness on the community, on the particular community. So how much of a financial burden actually it is causing, how many $1 million or how many million rupees actually it is causing. So we have to assess that, okay? Finding and applying the most appropriate eye care solutions for the particular community and for the particular country. So we, everywhere you cannot have the same strategy. So you'll have to rather formulate and plan your own strategy depending upon actually the situation in the particular community. So the eye care solutions, various eye care solutions actually which we use are, first and foremost is preventive activities of the control of the communicable and non-communicable diseases and environmental health hazards. Okay, so this is the first and foremost thing, the solution. And the second solution is promotive activities concerned with improved nutrition and intensive eye health education to the people, illiterate or to the educated also sometimes, and improved lifestyle. Okay. And thirdly, curative programs, which can really cure the disease of the individuals and reduces the burden of actually blindness in the particular community. So there are certain common eye conditions which cause like that they are refractive errors. Suppose in the case of refractive errors, if they are actually identified, you can as well prescribe glasses, the suitable corrective glasses, and the patient's vision definitely gets improved. And trachoma, though it was very, very common when we were children, nowadays actually it is very, very, the incidence has come down drastically, though it is present actually in the villages and remote tribal areas. Nowadays actually we don't see it, but the sequelae of trachoma, it is still persisting and it causes actually corneal scars, which results in corneal blindness again. So that can be actually reduced by certain programs. Okay, and next, cataract. So the major chunk of actually blindness in India is because of the cataract. There are really about 16 to 20 million population which are bilaterally blind with the cataract. Suppose if they are operated and that is evaded. Okay, xerophthalmia. Previously, vitamin A deficiency, it is used to be actually the cause for keratomalacia and also the loss of vision of in the children. those people not the deficiency of vitamin per se, but it is almost always associated protein energy malnutrition and certain disorders actually which reduce actual vitamins and everything in the body and this okay. So next we go on to the various definitions of blindness. Blindness evidently rather literally it means actually it is the loss of vision and the absence of perception of light and projection of rays also. But there are different types of actually the definitions we had given. First one is an economic blindness. So the economic blindness is that level of blindness which prevents an individual from earning his daily bread and butter, okay, or daily wages. So here actually the presenting vision is less than 660 in the better eye with the best possible correction. So since the level of impairment hinders actually the individual from earning his daily living, so it's also called as work vision, okay. And these definitions we ask you in the orals and you will have to answer them. And legal blindness is another thing where actually the level of, this is the level of blindness where there are you should necessitates actually the introduction of the welfare measures and also legal protection. Vision less than 660 or 20/200 or less in the better eye with best possible correction and our visual fields of less than 10 degrees actually this comes under actually the legal blindness, okay. This definition normally it is used in the United States of America where actually there are certain measures, financial measures and other social measures which are given to these people who have got legal blindness, that is vision less than 6/60 or 20/200 or less in the better eye with the best possible correction or a visual field of less than 10 degrees. The other one is a social blindness. Here the degree of disability of the individual, it hampers him from socially interacting with the family and the peer groups in a satisfactory manner. The inability is to count the fingers at a distance of 3 meters with the better eye and with the best possible correction. So suppose these people because of whatever may be the problem or the disease which is actually causing all this. So they will not be able to identify any person or known persons when they are coming in the opposite direction. So they smile and these people, they keep a grim face. So that is actually causes social problems for these individuals. And since this level of visual impairment curtails the day-to-day activities or movement of an individual, it's also referred to as actually walk vision. Social blindness is otherwise known as a walk vision. So manifest blindness is the fourth one, I think. Vision here is less than 1/60 with the best correction, with the best correction. Seriously, it constrains actually the accomplishment of tasks for daily living and impairs mobility of the individual also. They will not be able to move like normal individual who has got a 6/6 vision. It is used as a service indicator as most of the cataract blind in the developing world are operated at this stage. Suppose the NPCB especially actually they say the cutoff point for the subjecting the individual for cataract surgery is around 660 or less than now 660 say now it is 660. So another thing is absolute blindness. So absolute blindness is nothing but a loss of perception, projection of rays, inability to perceive the light in any eye. Curable blindness is this stage of blindness where damage is reversible by prompt management. Example, cataract or corneal blindness also, when we do a keratoplasty, it is reversible, they will be able to see. And preventable blindness, this is the loss of blindness that could have been completely prevented by the institution of actually proper measure of treatment or preventive measures or prophylactic measures, such as in case of xerophthalmia, suppose a proper administration and prophylactic doses of vitamin A, both in actually the pregnancy, the ladies who are lactating and the children below 6 years actually with the proper doses and everything. So they will be definitely be cured of actually the ophthalmia, and they will not have any blindness. This comes under one of the preventable blindness. And trachoma previously, the institution of treatment at the earliest possible this thing before actually the onset of trichiasis or an entropion. So this can be prevented. Okay. So the other one is glaucoma. Glaucoma, suppose if the family has got history of glaucoma, so especially the primary open angle glaucoma. So these people, they should be on lookout actually for getting it diagnosed at the earliest in case it occurs. From the age of 40 years, at least from the age of 40 years, every year they should actually go in for routine ophthalmological examination, laying emphasis basically on the measurement of intraocular pressure, and secondly, fundus examination, and thirdly, visual field examination. All these things, they are important. And glaucoma also, it comes under preventable blindness only. Okay, so especially the primary open angle glaucoma, it is rather a silent killer of the vision, and so one will have to be careful. Suppose the parents or the siblings, they have actually the glaucoma. Avoidable blindness is another thing. This is nothing but sum total of curable blindness in India. About 85 to 90% of the blindness is avoidable, especially cataract. Incurable blindness, here actually the state of blindness which is beyond redemption or beyond cure. So it accounts to around 5 to 10% of the blindness. So the World Health Organization accepts a cutoff of visual acuity of less than 360 in the better eye with best possible correction to define blindness. So according to the WHO, it is less than 3/60 in the better eye with best possible correction to define blindness. According to National Program for Controlling of Blindness, visual acuity less than 660 in the better eye with the best possible correction to define the blindness. So even now we operate actually when the vision is around 660 or less than that for cataract surgeries. So NPCB, as I already told you, this can be given as a short notes for you people, especially 4 marks question. So the National Program for Control of Blindness. So this is the expansion of NPCB, and it was launched actually way back in 1976, and it was started as 100% centrally sponsored program since its inception. In 1982, actually, it was included in the Prime Minister's 20-point socio-economic programs. So overall objectives of NPCB are, the first and foremost is provision of comprehensive eye care facility at primary, secondary, and tertiary healthcare level. Primary healthcare level is primary health centers, where you have actually a paramedical ophthalmic assistant and also mid-level community workers. Okay. And secondary healthcare, we have actually the district headquarters hospitals where you have an ophthalmologist and also an optometrist or paramedical ophthalmic assistant. And tertiary healthcare levels, actually we have in almost all the medical colleges and also the corporate hospitals, which are really only meant for the eye care. Okay, so these are primary, secondary, and tertiary healthcare, and this provision of healthcare, comprehensive eye care facilities at these 3 levels is the first and foremost objective of NPCB. And secondly, to achieve a substantial reduction in the prevalence of eye diseases in general, and overall reduction in the prevalence of blindness to 0.3% by 2020. I think we have not achieved it yet. Okay, so initially it is around 1.8 or so, and then I think we are around 1 or so now, and 0.3% actually it will have to be reduced. That is actually the initial goal. So the components activities under National Program of Control of Blindness are, the first and foremost is creating an infrastructure for cataract surgical and support services. So previously, when way back in 1980s or early to that, so what we used to do is we used to conduct the cataract camps, go to the villages, take a school or anything room, rather fumigate it, conduct the camp, and we used to do intracapsular cataract extraction for those people, and institute post-operative treatment, and finally we used to give aphakic correction and then leave. So nowadays actually it has changed. Now we are not actually operating at the peripheral level. So the district headquarters hospitals and also the tertiary care medical college hospitals, they are equipped with a lot of infrastructure. And the patients, they are being brought actually even after conduction of the camps from the periphery to the base hospital. And here we do it. Now actually the most of the cases it's only an extracapsular cataract extraction, be it actually conventional one, very rarely. And small incision cataract surgery, most of the cases are phacoemulsification and laser assisted phacoemulsification. All these things, they are actually being done nowadays. Okay, so it is done at the base hospital only. We don't do it. So for that, actually, one will have to create an infrastructure for cataract surgery and post-operative services, support services. So the second thing is school eye screening and refraction services. So if you take actually in most of the rural and tribal areas, so the children actually, they are not aware actually they have a refractive error. So they go on actually moving down because the person just in front of them is clearly seen, but at a distance they will not be able to make out. So these people, suppose if they go to the school, the teachers actually, they can identify that the individual has got a defective vision because they will not be able to see the board and write down what actually is written on the board. So in that conditions, actually the teacher can as well refer the boy or girl to the particular ophthalmologist or paramedical ophthalmic assistants in the PHCs. The school eye screening program is also conducted actually nowadays under the DBCS, this thing, and refraction services. So those people who are actually having a defective vision. So you conduct a camp, you go to do the school eye screening program to all the children. And suppose if the people who have got defective vision less than 618 or so, or even 612, 69 also, they can be referred to actually the primary healthcare, primary PHC, primary health center, and where actually we have paramedical ophthalmic assistants with the necessary equipment. They can do a subjective refraction if they have actually an autorefractometer, or else actually they can as well do a cycloplegic refraction and post-mydriatic test and prescribe the glasses. And the glasses can be brought, and that solves actually the refraction problem in the school going children. And strengthening actually eye health education activities is another component which comes under NPCB. So finally, the control of corneal blindness, including establishment of eye banks, which is being done. And that's also another component activity under NPCB. So there are 4 activities under NPCB. One is creating an infrastructure for cataract surgical and support services. And second one is school eye screening programs and also refraction services to the school-going children. And strengthening eye health education activities and control of corneal blindness, including establishment of eye banks. So these are the things actually. As per survey way back in 2001 to 2002, the prevalence of blindness was estimated to be around 1.1%. And in 2006 to 2007, they have done actually rapid survey of avoidable blindness conducted by NPCB, under NPCB, during 2006 or 7. They showed a reduction in the prevalence of blindness from 1.1% in 2001 to 2002 to 1% in 2006 or 7. So various activities or initiatives undertaken during the 5-year plan under National Program of Control of Blindness. They are actually focused towards achieving the goal of reducing the prevalence of blindness to 0.3% by the year 2020. So there are lot of causes actually which causes this blindness. And cataract actually, it contributes to nearly about 62.6% and 63%. Refractive errors of up to a tune of nearly about 20%. Corneal blindness 1%. Glaucoma around 6%. Surgical complications post-operatively, so it can give rise to around 1.2% or 1%. And post-cataract surgery complications such as a posterior capsular opacification, which can occur actually after the cataract surgery, it accounts for nearly about 0.9%. And posterior segment disorders such as, say, vitreous hemorrhage or PVD, PVR, or retinal problems or optic nerve problems, all these things they account for nearly about 4.7%. And the others 4.19% congenital abnormalities are the ocular congenital abnormalities. So estimated national prevalence of childhood blindness and low vision is around 0.8 per 1,000 population. So goals and objectives of NPCB in the 12th plan. So the first and foremost is to reduce the backlog of blindness through identification and treatment of blind at primary, secondary, and tertiary levels based on assessment of the overall burden of visual impairment in the country. Okay. So we'll have to make a survey and find out, and we'll have to reduce the backlog of blindness by proper treatment at the primary, secondary, and tertiary levels. And second one is develop and strengthen the strategies of NPCB for eye health and prevention of visual impairment through provision of comprehensive eye care services, medical treatment or surgical treatment, and quality service delivery. So all these people, they will have to be given quality service delivery. So previously we used to do an intracapsular cataract extraction. Nowadays actually it is not, we're not doing it actually. So phaco emulsification or with a small incision, definitely the quality of service is definitely better for cataract surgery patient. That sort of quality service delivery should be given. Strengthening and upgradation of Regional Institute of Ophthalmology to become center of excellence in various subspecialties of ophthalmology. We have various subspecialties. One is cornea, and second one is actually glaucoma, and third one is actually you have pediatric ophthalmology, oculoplasty, neuro-ophthalmology. There are a lot of subspecialties in the regional eye institutes of ophthalmology. We have one regional institute of ophthalmology of excellence in Delhi, Rajendra Prasad Institute in AIMS actually. And there were some proposals actually to make the regional eye hospital in Vizag to make it actually in arrival, but it has not materialized as it. So these things actually, again, strengthening the existing and developing additional human resources and infrastructure facilities for providing high quality, comprehensive eye care in all the districts of the country. So this will have to be accomplished by spending money and everything. The government's budget on health is very, very less. So there are certain foreign countries actually which are giving a lot of financial aid all over the world, WHO and other things, Danida and all these things. They are giving actually a lot of financial aid to boost up actually the various infrastructure facilities for providing high quality comprehensive eye care in almost all the districts of the country. So again, to enhance the community awareness of on eye care and lay stress on preventive measures. So even now, actually, we see the patient has got a strabismus. There are people who think actually it is a lucky sign for them. So they don't understand actually this strabismus can be of serious nature. Maybe in children with a retinoblastoma, they may present with actually strabismus. So they will have to rather increase the actually community awareness on eye care and also the problems of the eye and lay stress on preventive measures. Okay, suppose if the patient has got actually conjunctivitis, a viral conjunctivitis, even now there are people who will actually pour some onion juice into the eye. They think actually the all the membranes which are formed because of the disease, they will be broken by that. So it is all stupidity. There are ignorance on the part of the individuals, and so there's some people say encourage it. So we have to actually give them rather and educate them regarding all these things. Okay, they stress on preventive measures. So they should not do all these things. And suppose if they pay patient in the, if there is a patient with the conjunctivitis in the house, so the same format such as towel or handkerchiefs, all these things, they should not be used by the other people. All these things actually they should be made aware of. And to secure actually participation of voluntary organizations, private practitioners in eye care. So there are certain voluntary organizations, Lions and Rotary, all these people, they used to take a lot of rather participation in eradication of the blindness in India. I think nowadays it has come down a little. And private practitioners solely practicing not in the government service or in the corporate hospitals, they should also be taken into confidence, and they should secure their participation also in prevention of the blindness. So the three major refractive correctives which is to be provided to the population is, so not only myopic correction to the skilled children, so they can be hypermetropes, they can be actually the people with an astigmatic error. So whatever it is, like cycloplasic refraction must be done for those individuals, and a post-mydriatic test must be done depending upon actually the cycloplasic use, and prescription of glasses must be given, and the parents must be advised in such a way that they should see that actually the children, they use the glasses. So what happens is most of the times actually we prescribe glasses and they take the glasses and they don't use the glasses. And finally, if the refractive error is a very high one, so these people, they become amblyopic. Okay. And secondly, after 40 years, you know pretty well that most of the individuals, maybe you also sometime later, say after 20, 25 years, 20 years later, you may become presbyopic. So because that is nothing but a receding of the near point. So these people, they will have to be given correction, near correction with convex lenses. So aphakic correction to be to the operated cataract patients, nowadays it's not a problem, because so we are all we always do an intraocular lens implantation after an extracapsular cataract surgery. Suppose inadvertently even the PC is torn and there is not enough PC actually for implantation of lens in the posterior chamber, on the PC, nowadays we do actually what is called scleral fixation lens or iris clip lens. All these things can be done, and there is no need for actually an aphakic correction in the post-operative cataract patients. So intensive health education activities are central to the success of actually NPCB. Okay. And information, education, and communication activities have recently been augmented for helping to reduce actually the blind in our country. So corneal blindness and eye donation is another thing. For this purpose, National Program of Control of Blindness supports the establishment of eye collection centers. So where you can have actually the certain media, Mechanicus medium, medium, all these things, or an eye splash can be there. So suppose if the patient is dying and there are counselors will be there in the ICUs, and they will actually motivate the relations, kith and kin of the person who is brain dead or who dies immediately after the death of the individual for corneal donation. And we can actually remove the corneal button and keep it in actually an ice flask. And these collection centers actually, they are given to the certain colleges. So they can be kept, and later on we transport this tissue to the nearest eye bank. So in Vizag, actually we have only one eye bank, that is Mohsin Eye Bank, okay, both in the government. So there are, the Mohsin Eye Bank actually is under NGO sector, and we have eye banks in, I think Sarojini Devi Hospital, and that's a government one, and LV Prasad Institute in Hyderabad, that's a private one again. Okay, so World Bank assisted cataract control project is another thing which was initiated way back in 1994. So under this World Bank assisted cataract control project, they have identified nearly about 7 states where the prevalence of blindness and the backlog of operable cases, cataract cases, was the highest actually in the country. So in order of descending prevalence, first and foremost is Uttar Pradesh, next Rajasthan, Madhya Pradesh, Maharashtra, AP also used to contribute a good chunk of the cataract blindness, Orissa and Tamil Nadu finally. So in these states, for a period of nearly about 7 years, from 1994 to 2001, they have augmented actually the cataract services, and they started doing more cataract surgeries. So nearly about 11 million cataract surgeries were planned to be done during that World Bank assisted cataract control program project. So Danish International Development Society, our agency, has been assisting National Program of Control of Blindness since 1978. So the DBCS, District Brightness Control Program, Control Society, is a concept of Danish International Development Agency, and it was first successfully has been tried by the Danish International Development Agency. Because India is a very big country and the population is really very, very huge. So unless the services are decentralized, you will not be able to do the justice and reduce the height of blindness in the country. So that's the reason actually District Blindness Control Society, this concept has been introduced by the Danish International Development Agency. It assisted actually in the NPCB since 1978. This vision screening and programs in the schools have also been pioneered by the Danish International Development Agency only. So here actually we take the help of the teachers who initially identify the children who have a defective vision. Sometimes our paramedical ophthalmic assistants, they go to the school and they examine actually all the children by keeping actually the vision charts as to 6 meters distance. And they identify the people with defective vision and try to bring them actually to the base hospital. And we do cycloplegic refraction, do the fundus, and then prescribe them the glasses. Sometimes we give them free glasses also. In the third one is, in the current phase of assistance, the Danish International Development Agency, it has adopted Karnataka as a pilot state, and it started funding all eye care activities in that particular state. Phase 3 of DANIDA assistance is being implemented since 1997. So again, the International Department of International Development of the UK, it has successfully and actively was collaborating with the Government of India in strengthening the community ophthalmology services in India. So organization of NPCB, what is the structure of NPCB? We have National Program for Control of Blindness. So the first and foremost is National Program Management Cell, which is in Ministry of Health and Family Welfare in Delhi, and the State Program Management Cell, which is again in the Director of Medical Education Office, and District Blindness Control Society, which is actually in the district hospital. So the medical superintendent, ophthalmic surgeon, and district mobile unit will also be there. District Health Officer, Chief Medical Officer, or Community Medical Health Officer, and mid-level program workers and all these things will be there. Primary health centers, we have Primary Health Officer, a medical officer, and also MPW will also be there. So next we have actually Vision 2020, so the right to sight. It is again a global initiative launched by the World Health Organization, and a task force of international non-governmental organizations. So the idea is to combat the gigantic problem of blindness in the world. And it was launched in Geneva on February 18th, 1999 by the then Director General of World Health Organization, Dr. Gro Harlem Brundtland. So the Right to Sight the program, or Vision 2020, it envisages collaboration between governments and World Health Organization and international agencies for prevention of blindness, and funding agencies, international non-governmental and private organizations that collaborate with the World Health Organization in the prevention and control of blindness. Globally, we have around 5 conditions which have been identified for immediate attention for achieving the goals of Vision 2020, which are actually causing the major chunk of for blindness. The first and foremost is the cataract, and second one is trachoma, and third one is onchocerciasis, childhood blindness, and refractive errors and low visions. These are the 5 conditions actually which are causing major contribution towards the blindness in the world. These conditions, they have been actually chosen on the basis of their contribution to the burden of blindness in a particular community or particular country, and the feasibility and affordability of our for controlling it, okay, of intervention to control them. So each country will decide. So every country will have to decide their own priorities based on the magnitude of specific blindness conditions in that particular country. Onchocerciasis actually is not prevalent here, but cataract and other things, they are more prevalent. In United States of America, trachoma is also prevalent here. In United States of America, age-related macular degeneration and glaucomas, they are more prevalent there. So depending upon it, each country will have to decide its priorities. Okay. So under this initiative, 5 basic strategies to combat blindness are promulgated. So the first and foremost is disease prevention and control. Second one is training the personnel in the particular field to do this job. And thirdly, strengthening the existing eye care infrastructure. So we need to have a good infrastructure actually to show the best results. So the existing eye care infrastructure will have to be strengthened by the government to achieve the goal, and use of appropriate and affordable technology. So whatever technology is there, we should be able to use it. And mobilization of resources. So the first and foremost is a cataract. This causes actually a major cause of blindness in the world, and then in India actually it is also the major cause of blindness, because there is already a backlog, though we are operating, and fresh cases that are being added to the backlog. And so there are nearly an estimated 16 to 20 million people who are bilaterally blind from cataract, and as I say, at any time, and the number is increasing because the fresh cases that are being added. And cataract surgical rate is defined as number of cataract operations per million population per year. It's a quantifiable measure of the delivery of cataract services. So it's meaningful, this cataract surgical rate actually, it is meaningful to estimate only when there is ample information on all the cataract surgeries that are being performed all over the country, including the private sector. So the aim is the elimination of cataract blindness. Person with vision less than 3/60 previously, now it is actually 6/60 in both the eyes or in either eye. Okay. So there are certain targets promulgated by the government. So these are the targets. And global cataract surgical rates targets 1995 to 2020. These are the things. And next we have actually trachoma. An estimated 146 million population or people have been having the active infection with the microorganism chlamydia trachomatis, And we have actually, we used to give most of the cases actually the antibiotic treatment, tetracycline ointment, azithromycin capsules or ointment also nowadays we are doing. There are approximately about 10.6 million adults with trichiasis or entropia for which eyelid surgery is needed. Otherwise, these internal lashes, they may rub on the cornea and cause scarring and in result, they end in actually corneal blindness, necessitating a keratoplasty. So an estimated 5.9 million adults are blind from corneal scarring due to trachoma. So trachoma is the second cause of blindness in sub-Saharan Africa, China, and Middle Eastern countries. Trachoma is to be controlled through implementation of the SAFE program strategy, SAFE strategy, integrated with the primary health care in all communities having trachoma within a country. So the SAFE, this includes assessment to identify communities with blind trachoma. And the first and foremost is delivery of community-based trichiasis. Trichiasis surgery by trained paramedical staff. So the trained paramedical staff actually, if there is trichiasis, they can as well do an epilation with an epilation forceps. And secondly, so the other surgeries we do for trichiasis, I think it will have to be done by an ophthalmologist only at the base hospital. So not anywhere in the rural areas. So antibiotic treatment, we used to give tetracycline ointment or oral azithromycin. Nowadays, azithromycin ointment is also available, both for the children with active diseases, AFERS, A of SAFE, and promotion of facial cleanliness and environmental improvement. So the knowledge how actually the disease is being spread, and now use regarding fomites and all these things actually we have to educate them, and including personal hygiene and community sanitation as part of primary health care will also be done. And aim is the elimination of blindness due to trachoma. So this is the aim actually under 2020. So these are the various global trachoma targets for cases of trichiasis and active infection. So onchocerciasis again is another disease of one of the 5 diseases which used to cause a lot of blindness. An estimated 17 million population are infected with onchocerciasis. Approximately 0.3 to 0.6 million are blind from this disease. It's onchocerciasis is endemic in nearly about 30 countries of Africa and occurs in few foci in 6 Latin American countries and also in Yemen. Elimination of blindness due to onchocerciasis is important. So nowadays we used to use actually ivermectin, 12 milligrams or so, the doses. So for treating actually the onchocerciasis. Okay. Childhood blindness is another thing actually which is there, which is crippling the children. The estimated 1.5 million blind children in the world, of whom 1 million, they live in India, they live in Asia, and about 3 lakhs in Africa. So prevalence is around 0.5 to 1 per 1,000 children aged 0 to 15 years. An estimate of 5 lakh children going blind each year, 1 per minute. So many of these children, they die off in their childhood because of the other infections, protein, calorie, malnutrition, or some other infections, okay. So it is estimated that blindness causes about 75 million blind years. So blind years actually they are calculated, but the number of blind in the length of life. And it is definitely second to cataract. So the cause of childhood blindness vary from place to place and change over time. In our country, actually previously, gonococcal ophthalmia neonatorum actually used to be One of the leading causes previously, because of the good institution of treatment and aseptic measures, and also prenatal checkups of the mothers and everything, actually it has reduced actually the incidence of gonococcal ophthalmopathy. The aim of this is actually to eliminate avoidable causes of childhood blindness. Okay, so the major causes of blindness, the childhood blindness in Africa, is corneal ulcers, scars, measles, vitamin A deficiency, and harmful traditional practices, and congenital cataracts and hereditary disorders. In Asia, vitamin A deficiency again, congenital cataracts, rubella, hereditary retinal diseases, all these things. In Latin America, it's again congenital cataract and glaucoma, congenital glaucoma, and rubella, retinopathy of prematurity. This is another thing. And industrialized countries and urban centers, retinopathy of prematurity, congenital cataracts, and hereditary disorders, they contribute actually as the major causes of childhood blindness. So vitamin A deficiency, previously we used to see a lot of cases, beta spots, Malaysia, and all these things. But nowadays it is because the awareness in the parents has increased, and the dietary supplementation of vitamin A is also increasing. Unless they are frequently have the diarrheas and protein energy, protein calorie malnutrition, all these things, very rarely we see actually the people with vitamin A deficiency. So the aim of actually reducing the vitamin A deficiency is to achieve and sustain the elimination of blindness due to vitamin A deficiency. Surgically avoidable causes to control blindness in children, there can be congenital cataract, congenital glaucoma, and retinopathy of prematurity, which occurs in children actually who were given oxygenation in premature children. Refractive errors and low vision, they contribute actually a major chunk of actually childhood blindness. And spectacles are essential part of the treatment of many eye patients. So we have to rather do a refraction depending upon the age of the individuals. We use a particular drug. Suppose if they are 5 or less or 8 or less, we use atropine, and we do a post-mid-radiate test after about 2 to 3 weeks. And if they are actually less than 40 and say 8 and 40, so we can use actually hometropine or cyclopentolate or clopidogrel, and depending upon the drug use, you can do the post-mid-radiate test. And in the adults, actually after 40 years or after 50 years, when actually the cycloplegia will not actually of much importance. Only dilatation will do, and we'll try to do actually retinoscopy and post-mid-radiate test. And nowadays mostly we are taking actually reading with an autorefractometer, and we are actually prescribing glasses after subjective verification. So the spectacles, as I said, they are an essential part of treatment of many eye patients with refractive errors. Their provision is therefore an integral part of eye care delivery. The steps in the provision of refraction service and low vision care, as I said, screening. So identification of the individuals with poor vision or a defective vision, which can be improved by spectacles or other optical devices. So any individual above 40, presbyopic correction is a must. In such cases, we can do refraction. We can as well correct for distance and also the near vision. And school health services, actually, we do the routine vision examination. Suppose if they have the problem, we try to prescribe the glasses. And refraction, evaluation of the patient to determine what type of spectacles, am I hypermetro or a myope, okay, or an astigmatic. So depending upon actually the type of refraction, we prescribe the glasses. So the manufacturer of spectacles are an appropriate device. So both of which may be manufactured locally or purchased externally, or it can be donated. Suppose if the patient actually can afford to buy it, they can as well buy it. And there are certain agencies actually which give free also. Okay. And the NPCB or District Blindness Control Society. So we are actually supposed to give those people who cannot purchase these spectacles after surgery, and also in the after school health programs, we give them the free spectacles. Issuing the spectacles, ensuring a good fit for the correct prescription. And these people, they will have to be followed up nearly every year. And if necessary, repeat dispensing must be done. So the aim is actually elimination of visual impairment, visual less than 6/18 or so, and blindness due to refractive errors or other causes of low vision. So the aim goes beyond the elimination of blindness and also includes the provision of services for individuals with low vision. I think we'll stop here. Okay, we'll take up from human resources development community level in the next class, maybe on Wednesday. Okay. If you have any doubts, you can ask. So these are the things actually which you'll have to read multiple times and keep it in mind and get it by heart. So as I told you, it is a very dry topic, and there are certain things which are very, very important. The first and foremost is NPCB can be given as a short notes, 4 marks question, and a DBCS, 2 marks question or 4 marks question, depends. Right to sight, Vision 2020, all these things, and the other definitions which I have there to mention, actually, they will be asked in the orals mostly. So we'll ask you what is legal blindness, what is other things, okay. Avoidable blindness, curable blindness, all these things, okay. Any doubts? Okay, thank you. I pen classes. Well, thank you.